Dr. Soveeta, sorry, RATH, please present.
Good afternoon, everybody. Esteemed panel. So I would be discussing about misleading pale disc, a series of Wolfram syndrome and how we studied them. Let me begin with the story of this 9-year-old boy who presented to us with diminution of vision both eyes, 6 months in duration. At presentation, visual acuity was 6'9", 6'12", with a drop in color vision as well. He read only 7 plates, however, there was no RAPD. Anterior segment was normal, and fundus showed disc pallor both eyes with a dense temporal pallor. He came to us with these VEP reports, which he carried as was advised elsewhere, which showed that both eyes had prolonged P100. Now seeing this, what should be a diagnosis in a 9-year-old boy, both eyes diffuse pallor, prolonged P100? So is it juvenile glaucoma, or some hereditary optic atrophy, autosomal dominant or LHON, or a past episode of atypical optic neuritis has happened and gone? Is it a mild CVI or some IXOL causing compressive optic neuropathy? A pause, and then we retook a history, which gave us a clue that he had insulin-dependent diabetes mellitus, and on probing further, mild hearing loss. Is it DID mode now? With this, we also advised MRI, atrophic optic nerves were seen, no IXOL, no enhancement of optic nerves. Then a history was taken which was negative again for family history, pedigree was done, and a genetic testing was advised. We were fortunate enough that the patient could afford, so to find that presence of homozygous mutation in WFS1 gene, which now confirmed that it was DID mode. So Wolfram syndrome is a rare autosomal recessive genetic disorder with juvenile onset diabetes mellitus, insipidus, optic nerve atrophy, hearing loss, and neurodegeneration. First reported in 1938 by Wolfram and Wagner, where he found 4 of 8 siblings with juvenile diabetes mellitus and optic nerve atrophy. So it's an autosomal recessive entity with 2 prominent causative genes, WFS1 and WFS2, with early onset diabetes and progressive optic atrophy usually presenting in the first decade, cranial diabetes insipidus with sensory neural deafness in the second decade, renal tract abnormalities in the third decade, and multiple neurological abnormalities such as myoclonus, psychiatric illness in the fourth decade, causing prolonged morbidity. So what does literature say? Where is our role here? Yes, systemic associations have been elaborated more than ocular, but optic atrophy still forms a diagnostic criteria. However, subtle vision loss with mild disc pallor, as in our case, could present with or without ocular associations, can be the presenting sign. So a detailed systemic history and workup is necessary for early diagnosis and prompt management. This brings us to a study which we did during the period of 2021 to 2024 as a retrospective analysis with a minimum follow-up of 6 months. All children of more than 5 years were analyzed who had the diagnosis of DID mode on their files. A detailed history and symptoms of systemic associations were noted down. The ocular evaluation was noted down. In anterior segment examination, if there was any dry eye, LSED, cataracts, nystagmus, motility disorders, raised IOP or pigmentary retinopathy was noted, and in follow-up, all of these had undergone a Fields, OCT, RNFL, and MRI brain and orbit with a genetic evaluation. Adequate ocular management was done for them, and low vision services was provided. So we found there were 6 males ranging between 7 to 35 years with mean age of diagnosis 18 years. Our youngest child was 7 years, and our oldest patient was a 31-year-old female who developed gestational diabetes and was then found to have DID mode and diabetes. So diabetes mellitus, as noted in literature, was seen in 100%, and least was genitourinary abnormality in 22% of our patients. Optic disc pallor was seen in all of them, where 56% had temporal, 44 had diffuse. But we also had 10 eyes who had 56 cataracts, again, 5 of them belonging to 2 families, 3 siblings, 1 family, 2 siblings, 1 family. 6 eyes had overlapping glaucomatous cupping also. OCT was done, which showed retinal nerve fiber analysis thinning in all 18 eyes. The inheritance was autosomal recessive in a majority. Whole exome sequencing was done. 5 patients were positive for the WFS1 gene. 1 patient was positive for WFS2 gene. 1 adult had separate genes. The adult, who was presented at 35 years, had an OPI gene for diabetes and WFS1 gene for DID mode. So what does the literature say? Most of the studies discuss as systemic neurologic associations of DID mode. We did study the ocular associations. Optic atrophy and diabetes remains the presenting feature, diagnostic feature, presenting in first decade. Though in first decade, we saw that our series had earlier age of presentation. Hearing loss and genitourinary symptoms also remain common, which was seen in few patients. Genetics testing with genotypic phenotype correlation is a prognostic indicator. WFS gene was positive in 56 patients, but correlation was not done. OCT also showed indicator indicating poor visual prognosis. None except one had neurological implications during follow-up, that was cerebellar ataxia. Ocular associations like cataracts and glaucoma coexist. So it is a phenotypic heterogeneity entity with different clinical manifestations, located on chromosome 4p and encodes protein Wolframin, which shows that accumulation of misfolded proteins, and optic atrophy and diabetes thus remain consistent features. Even if children do not present with diabetic mellitus but have optic atrophy, they should be evaluated for Wolfram, as diabetes mellitus can present later. Effective follow-up should include a multidisciplinary approach. Thank you.
It's basically a neurodegenerative disorder which is characterized by the progressive visual loss and
Diabetes.
the hearing impairment. How many cases did you do audiometry?
We did in 3 cases, sir.
So
Audiometry
what was
done.
the pattern? There was a hearing loss?
Yes, there was hearing loss. We did provide hearing aid to 2 of them also.
So basically this is a progressive hearing loss and progressive vision feed that causes this.
How much was the follow-up period? You said progressive optic atrophy. So,
Ma'am, this was a retrospective study. So all those who had 6 months in our database, those we had pulled out.
so was there in the 6 months, was there any progression or
No.
it was just
No, they already had optic atrophy. Some of them were misdiagnosed as glaucoma, and some of them had cataracts.
was the genetic testing done in all?
5 out of 9 underwent genetic testing, ma'am.
In case they first present with optic atrophy without any diabetes, are there any other suspicious signs that you would like to work them up for Wolfram syndrome? Or would it be by exclusion that none of
It
the
is by
others are
exclusion, but
present?
now with literature, this is not very common. So with the literature, knowing the other ocular symptoms should also be looked for. Workup wise, only if you go back to history and find those 3 major criteria, then a genetic workup supports it.
Thank you.
Thank you.
Thank you.